Thank you so much for joining us, all of you, today. We're going to be talking about a fascinating subject that I think many parent carers struggle with the idea of being a therapeutic carer. And I think when we're therapeutic parenting, it frequently leaves caregivers feeling that they're doing things wrong or they're at fault. And today we're going to go into the details behind that. And it's a real pleasure to be able to hand over to both Anna Webster and Becky Govan. Can I ask you, first of all, Becky, can you talk about your lived experience here?
In terms of my lived experience, I have three wonderful children and a dog, as you can see on the photo there. It's one of the wonderful FASD therapy dogs, which I'm sure some of you either have or know about. Unfortunately, I haven't trained her properly, so she's kind of non-qualified therapy dog at the moment. But yeah, so the situation with our children is that we've got two birth children, me and my husband, and our boys, our twins, both have neurodevelopmental disability and neurodiversity, other than FASD. And then our adopted daughter, who is 7, coming up for 8 in August. So our boys are 10 at the moment. She has FASD. And I think what that gives me is a perspective. So one boy's got autism, the other one's got agenesis of the corpus callosum. So it gives me a perspective on how different needs present and how different disabilities present, on issues with siblings and family dynamics in that way, which I don't think gets talked about a lot or enough, and how difficult that can be and how challenging that can be. To try and meet everyone's needs is nigh on impossible, really, isn't it? So yeah, that's my lived experience. My learned experiences as a social worker, and carrying out my doctoral research at the moment at Birmingham City University into post-adoption social work, with families like mine and like many of ours in that post-adoption field of practice. And I'm in my final year of writing up my thesis currently. So I've been a social worker for 20 years, and I also deliver training with Anna as part of Neurowise.
Well, we wish you luck with the final thesis.
Oh, thank
It's
you. It's exciting
exciting
me.
times, I know. Absolutely. Anna, over to you.
Yeah, thanks, Andrew, and thanks so much for having us today. We're excited to be here. So I'm Anna, and I'm a coaching psychologist and psychotherapist in training. And my living experience is the little boy on the right there, who we adopted when he was 9 months. So there he is, looking a bit bewildered. It was his foster mum that put him in those funny outfits. He doesn't look very impressed with it, but yeah. And then on the right, on the bottom right, that's him a bit more recently, with our dog Mabel. He's now 13, and he was diagnosed with FASD at 3, and he also has the co-occurring usual diagnoses of ADHD and autism and learning disability, actually, which is a little bit more unusual. And yeah, he's a lovely boy, and he's got very high level complex needs. So it's from the case study of my little boy that inspired me to make a career change a number of years ago and do my qualification in psychology and start training as a psychotherapist. I've also worked for the University of Salford for a number of years on their specific programme. So I don't know if anyone here has been part of that, quite possibly. That's a psychoeducation programme for caregivers of children with FASD. So that inspired me as well to set up Neurowise, which is coaching and training. And we're going to talk a bit more about what we do today.
Excellent. Thank you so much. Well, listen, one of the great things is how we're going to explore how to adapt therapeutic parenting and caregiving so that it truly fits the needs of children with FASD and supports all well-being of the whole family. So let me hand over straight to you, Anna, and we'll do a Q&A at the end. Feel free to, all our guests are very welcome to put in any questions into the Q&A, and I can pass those on at the end of this session. So over to you, Anna.
Yeah, thanks, Andrew. Okay, so we're going to give you an overview of our adapted approach to therapeutic caregiving. And this started with some research that I carried out for my master's on the well-being needs of FASD caregivers. And this found very strongly that caregivers are unconfident in identifying their well-being needs. And they found that their needs were subordinated to the all-encompassing, overwhelming needs of children with FASD. So they sort of felt like they'd lost themselves a lot of the time, and their needs were just bottom of the pile. And I'm sure some of you will recognise that. So those are just some quotes that came from that research, just on how very difficult it can be to identify, for caregivers to identify what they need and to meet those needs. That research also found that caregivers found it specifically really difficult to meet these three key survival needs. We're calling it survival. And yeah, these three needs of sense of self and autonomy, connection and relatedness with other people, and self-worth and competence. All those three needs are actually really hard for people with FASD to meet. They are really difficult to be. So that means that it kind of knocks on to caregivers, and it means that caregivers can find it really hard to meet those needs as well. So that research basically led to setting up Neurowise and our approach to therapeutic caregiving, on the back of how hard it is for caregivers to meet their own needs, but also the finding from our research that many caregivers feel blamed and like it's their fault in terms of their experiences with their children. And a lot of that was around being told that it was attachment and trauma, and trying to use therapeutic parenting approaches that were developed for those, and it not being effective. And some of you might recognise that as well. So Beck's just going to talk through.
Yeah, thanks, Anna. I'm here. I keep coming and going. It's all going marvellously well. So in terms of the way in which we want to adapt therapeutic parenting, and we have been adapting therapeutic parenting with the caregivers and the courses and the training that we've been supplying, we want to really emphasize that we're adapting it. We're not throwing it out. We're not saying it's entirely ineffective, but what we are saying that our kids' brains are different, and the way in which we approach them, that needs to be acknowledged. That needs to be at the heart of all we do. That's the reality of what we live with day to day. So we've adapted therapeutic parenting approaches, as Anna says, based on the evidence that I really feel is kind of gathering pace around these approaches not being fully effective for our families. So the reasons that they're perhaps not fully effective is that they interpret challenges slowly through the lens of postnatal trauma and attachment, and that's very likely to overlook the impact of prenatal exposures, alcohol exposures, and other experiences that our children have had. But fundamentally, that difference that's been made to their brains and the lifelong disability that results from that prenatal alcohol exposure. So they can also fail to adequately recognise and support the needs and experience of caregivers and practitioners, in terms of our lived experiences, people being experts in their own lives, and really contributing that into the mix, that can be under-recognised, really. And just having that feedback professionally, I know that can be quite challenging for professionals to hear that an approach that they've been using is perhaps not as useful as they would have hoped it had been. And we need to try and think outside the box, and we need to adapt, and we need to be flexible, and we need to move on to something different perhaps. So all of that can lead to blame, shame, and unmet needs. And we know that with FASD, shame, stigma is running throughout it like a sticker rock on that previous slide. So we want to recognise that. We don't want to exacerbate it, and we don't want to make anyone feel like a failure as a parent. We know that so many of us are just trying to get through the day, doing the very best we can for our families. So this is a really helpful metaphor that we use a lot in our training. And if we could be really jazzy and get Zoom to do it, we would. But you can hear neurons wiring and firing in the background there when we deliver this live, in terms of the connectivity disorder. Oh, is it working? No, it's not going to work. The connectivity disorder that FASD is, and I think Anna first heard this at the FASD Ireland conference last year when Raja Mukherjee kind of said, it really is fundamental to understanding FASD that we understand that the wiring, the firing, those neurons, that so much of therapeutic parenting is based upon what wires together, fires together. Yeah, we've been taught that as a kind of a mantra. But what we're saying is that for life, that ability for our children's brains to wire and fire is fundamentally impaired. That's the reality of the situation. So those connections, sometimes they work, sometimes they don't, hence the spiky profile. The unreliable wiring flickers and misfires, okay? So that's what we're living with. And this can lead to disconnection and even functioning, and where strengths, which we absolutely want to recognise the strengths of our children and of people with FASD, and challenges vary from moment to moment, highly complex and highly challenging for everyone involved. So thanks, Anna. Just moving on. So here we've got this example of another reason why we need to adapt therapeutic parenting is that FASD very often involves very rigid thinking and difficulty with adapting flexibly. So the brain gets stuck like a gear stick that can't switch and shift gears. So we need to be adapting our approach. We need to be using different tools. We need to be thinking about how that brain's going to be able to learn and develop and grow. We know that fundamentally things that are really difficult are things like cause and effect. That there can be real rigidity around understanding that. Hence things like consequential thinking, which is very much part of therapeutic parenting. Having those conversations about consequences is really hard for kids with FASD, and very often they'll appear like they're just not getting it, and that can be really frustrating for everyone involved. Difficulty with adapting from situation to situation. So you might have those therapeutic type conversations in one situation and think, oh, did really well at that went really well, and then we're in a similar but maybe different context the next day and exactly the same happens, and you think, what on earth happened there? I thought we'd nailed that, but no. So really difficult, and we need to consider that as well in the mix when we're trying to support our kids.
Thanks, Beck. So I'm going to introduce our approach now, and it's based on acceptance and commitment therapy, and it's basically a response to those two key things about FASD. So it's building psychological flexibility in the face of that rigidity, that stuck gear stick, and also connection in the face of the disconnection of that faulty electric light bulb, that disconnectivity, that connectivity disorder. So ACT as an approach, as a therapeutic approach, is what we use for our therapeutic coaching. And it's also what we use for our dual track approach. So you've got the caregiver and the child there together. Basically, it's a dual track approach that we take for caregivers and for children with FASD. So we're not just about the child. And this is a real thing that we get feedback on all the time, is how much people haven't been asked about themselves. People often say, this is the first time somebody has actually asked me, how am I? How am I doing? And as we know, FASD is a really complex and challenging condition, and it can be extremely stressful and actually quite traumatic often for caregivers. So that focus, that dual track focus therapeutically on both caregivers and children is really, really vital. And we're asking, can it be both? So again, with that dual track, that integrated approach and that flexible approach, can it be both? So often that traditional therapeutic parenting, we know it's been developed for trauma and attachment. Can it be that we're looking at pre-birth traumatic experiences and exposures, importantly, to alcohol and other substances and often violence, and post-birth traumatic experiences? So pre-birth and post-birth, but also factoring in those exposures to teratogens, particularly alcohol. Can it be brain and mind differences? Can it be attachment patterns relating to pre-birth brain differences and post-birth experiences? So it's a bit of a mouthful, that, but basically the idea that attachment could be affected by the brain differences that are caused prenatally by alcohol. There isn't much research on this yet, but there needs to be, because just from anecdotal experience and from the experts in FASD, actually, like Raja and Cassie Jackson, it's clear that it just makes sense, doesn't it? That the changes in the brain that come from prenatal alcohol exposure affect how people attach and how they form relationships. And then finally, can it be both addressing the needs of caregivers and practitioners and the needs of people with FASD, as we've said? So it's this both and approach. People might be familiar with that, especially if you're kind of working in a therapeutic area. Both and rather than either or. If you think of the rigidity of FASD, it's often very either or, isn't it? Very black and white, very all or nothing. So we're talking about a response that is both and to counter that. Beck, I don't know if we're going to be able to do stuff in the chat. What do you think?
Yeah, I mean, there's nothing in the chat yet, so maybe we need to get some fingers moving and feeling more confident. I don't know, but yeah, I guess what might just be a simple way of doing it, Anna, is if we ask people to put in the chat examples of when they might have is that resonating with people? Really, I guess it'd be good to feel like we're resonating a bit with people. That rigid thinking that we've alluded to already in FASD. If you're living with that, you will have examples of that. So, for example, when Anna comes around my house, she knows that the cheese bag must stay in the kitchen. And tonight we had a lot of that. So my daughter has quite a lot of echolalia and repetition as well, verbally. So when I get the cheese out, I mean, everyone loves a bit of cheese. You want to know there's an unending amount of cheese, don't you? So she will just continuously say the cheese bag must stay in the kitchen. That's a rule. And if I put the cheese bag back in the fridge, then I am in, I'm in trouble. We're close to a meltdown then. So that kind of rigid all or nothing thinking, that kind of, I have to do this, it's with my autistic son, I know it's not FSD, but we see this in other neurodiversities as well, don't we, that you might be living with. We have these diagnoses as well, don't we, for our children. So he'll either say, I have had the best day ever, or it's been the worst day ever. So yeah, I failed today. I know a lot of our kids find education really, really difficult. So if you're having those kind of experiences, please put them in the chat.
Sorry, ladies, can I just jump in for 1 second, just to let you know, it's Q&A. The chat's disabled for this.
I'm so sorry. Yeah,
this webinar. But please, everybody, put in any questions you want into the Q&A, and we'll monitor it from there.
Yeah, I'm seeing something.
And also, sorry to interrupt, but Annie O'Neill has had a hand raised for a bit.
Oh, Annie, okay. Sorry, we weren't ignoring you. Did you want to leave that till the end, or is that? But no.
And Ruth and Gregory as well. Is there a way of, how does this work? And Alison Flanders.
What we'll do, any questions that come up, we'll put them into the Q&A. And if you both want to monitor that while you're going and answer, that's fine. Or you can leave it to the end. It's entirely up to you.
I do apologise because I wasn't here at the beginning. I think I missed that the chat wasn't working.
Not a problem.
Yeah, absolutely. Please please use the Q&A. Sorry for any confusion there. So we're just giving an example of day-to-day life with FASD, aren't we? There is just, I'm perpetually confused. So I have to say perfectly regulated, or I'm harming them. I think that's as a caregiver, we can really feel that. I'm either a therapeutic parent or I'm doing a bad job. I think that's sometimes the messaging that we've been given. I need to fix this. Or my kids either going to develop and learn, or they're not. Whereas we know that sometimes in life we have these kind of spurts where we're able to develop and learn, and sometimes it's more difficult for us all as human beings. So any examples of when you as a caregiver, maybe if you're a caregiver here today, feel like there's that rigid thinking for yourself, and you're okay to share that, obviously within your own comfort, or there's that all or nothing thinking from your child or young person. So here we go. Thanks, Annie. The rigidity is massive, causes major problems. Both my children only seem to care about their own needs. I think that rigidity very much becomes a dictating factor for family life, doesn't it, Anna? We talk about this quite a lot, when you're just feeling like, oh my goodness, there are other people in this family, we all have needs. So for example, my daughter just wants me to take her swimming to the training pool, whereas my boys want to go in the big pool. And every time we go swimming, that's a whole thing, that she doesn't get to always go in the pool she wants to go in. So yeah, you can feel very dictated to by this kind of rigid thinking. And that can be really, really hard and really draining. I often lose my own ability to self-regulate. That's completely normal. I think there's this superhuman view of caregivers that we're able to regulate at all times, and then offer co-regulation to another person in our life. I don't know a human being that can do that at all times. That's just not possible, especially with the chronic and acute stress that we're all under. So being self-compassionate and kind to ourselves is something within the ACT model as well, that Anna and I talk a lot about. Shall we move on?
One of the things that people talk about on the programs is the relief at being able to go, okay, it's just normal to not be regulated all the time. And that's all of us that are obviously under high amounts of stress and pressure. And it's just, we're not superhuman. And then there's that relief of, it's okay to feel like that.
Yeah, and one of the most powerful tools that we teach from the ACT model is talking to yourself like you would a good friend. And I think if your good friend came along and described like a typical day, like most of us here who are living the reality of loving someone with FASD, you talking about the challenges, maybe the sleeplessness, not getting to do what you want to do with your day, having your day dictated to, or feeling that at least, perhaps behaviours around maybe child-to-parent violence or aggression, behaviours that can feel quite scary for you and the other people in your family and your child with FASD, perhaps educational challenges and calls from school. If your friend described all of that, you wouldn't be telling them off, would you? You wouldn't say, well, you should be regulating more, shouldn't you? You need to just go ahead and do some more regulating. That would not be the response. The response would be, oh my goodness, that is a lot. How can I help? That's so much for you. That sounds tough, and just offering that compassion and kindness can make all the difference, can't it? So yeah, let's move on to the next slide, Anna. Thank you for sharing, Annie. We really appreciate that. So again, the reframes and the both kind of thinking that I've learned a lot about on this journey, really, particularly from Anna and other kind of therapeutic based practitioners. Today, so instead of I failed today, we've got today was really hard, and one difficult day does not define me. I'm good enough. They're calm at school, so they should manage at home. We get that a lot, don't we? We get a lot of the masking at school, and then other relatives or well-intentioned people saying to us, well, they were fine with me, so I don't know what the problem is. It's the kind of intimation, isn't it? We get that a lot. They may use a great deal of energy holding it together at school, and home may be where their stress finally shows up. I have to stay perfectly regulated or I'm harming them. My regulation matters, and I do not have to be perfect. I need to fix this, as opposed to I can support and guide them, and I cannot fully control things. Yeah, so that acceptance as well. So over to you, Anna.
Thanks. So that's just an example of what we mean by this approach, this ACT approach. And if you want to do this quickly yourself, a good kind of metaphor for this is if you clench your fist really tightly, that's like kind of either or rigidity that we see a lot in our children. Notice how tense and narrow that feels, and then try just slowly opening your hand. And that's the both and flexibility, because it's also about a wider, more spacious kind of approach and allowing more space and looking outwards more, because we can get very caught in the narrow kind of tunnel, can't we, of survival, quite frankly, when we're dealing with these kind of challenges. Okay, so now we've outlined the kind of ACT dual track approach, we're going to move on now to the model of Sparks. So this is where it gets clear about the alternative to therapeutic parenting. So we're just going to quickly run through the elements of this. Obviously, there's only so much we can do on this short webinar, and this is something we go into detail in the program, in the caregiver program and training that we do. But it shows above the arrows, it shows what it's moving from in therapeutic parenting. And as Beck said, we're not doing away with therapeutic parenting, we're adapting it. So first of all, you've got space. So this is moving from an idea of proximity and constant togetherness that we might have picked up from stuff that's more about attachment, where you just have to be really, really together and attuned and always together and kind of proximate and close. And actually in FASD caregiving, there's a need for external and internal sense of space, a bit like I just talked about, but also practically rest and respite, absolutely crucial, and I know really hard to come across for a lot of people, but really crucial. Separate spaces, that can seem controversial when we're thinking about the sort of traditional family setup where we're all together. For example, having meals together, often it works much better for people to be in separate spaces and for people to eat, people with FASD to eat separately, say with an iPad. So really validating that and saying, no, that's okay, that's what's needed. Limits on one-to-one time. So a bit like what's used in schools with change of face. There needs to be more of that wherever possible. Tag teaming, change of face, fresh energy coming in, just to open up that space, but to give us space, to give caregivers space, and also to create that safe distance that's needed at times. Because obviously when we're dealing with aggressive and violent behaviours as well, we need safe distance. We can't always be close together, and sometimes we need to walk away and create that distance. Okay, on to you, Beck, for positive.
Yeah, so what we're not saying with positive, so here we're taking the kind of playfulness from the pace side of things. What we're not saying with positive is we're weighing in heavily with positive psychology. You should feel happy all the time. You should feel positive all the time. Get yourself some affirmations and you'll be fine. That is not what we are saying, just to be really clear. What we are saying is that there is a need for playfulness at the right time with our kids. And validation for caregivers as well. Fun is really underrated, isn't it? In terms of life can become so serious for us as caregivers. We're dealing with lots of unresolved feelings around grief and loss, and chronic sorrow is a theory I've applied in my PhD so far, and I think it's really relevant. We're raising children with disabilities. We don't know what the future may hold. We absolutely believe at Neurowise that people with FASD go on to live meaningful, productive, and great lives. but we also know there's challenges in that. So to kind of counter that, we need some fun, we need some space, we need some fun, we need some lightness, we need to find things we enjoy. I know Anna's research found that caregivers had just forgotten what they used to enjoy, or they hadn't done it for years. They hadn't even thought about doing anything like that. It seemed completely unrealistic when they're so busy and they're so committed, and they've got so much going on at home. We also really find that from talking to caregivers and from our own lived experience, that kind of upbeat energy is really helpful for our kids. And that's why Change Your Face, kind of connects to this, because you can't be upbeat and give energy every single minute of every single day, but that does really help. So if you're done with it and you can't carry on, there needs to be, and this is where we absolutely respect solo caregivers as well, in terms of how are they supported and how is that support network coming in when they can't continuously give that energy. That's just not realistic either. So validation, lots of affirmation and praise for our kids, because that kind of brain is more towards the kind of negative bias, and we need to turn that, and we need to start to kind of really affirm, and sometimes again that takes lots of repetition and energy. One-to-one attention, humor. Anna and I have started in the past few weeks singing our feelings, haven't we, Anna? We've been experimenting with that, and it can be fun, and also you're getting them out, aren't you? So yeah, that's positive as we're kind of perceiving it in this model.
Yeah, thanks. And somebody said in the Q&A earlier about having to always say yes, and even a no, couch it as a yes. And that is about the negative bias in the FASD brain. And it's wearing, isn't it? It's hard to always have to do that. So that is, again, why, like as Beck said, we need change of face and rest as much as possible, because especially if you're dealing with challenging behaviours, it's not easy to have positive, upbeat energy in face of that, is it? Architecture is the next letter of Sparks, and this is really similar in some ways to the principle of scaffolding that you'll find in therapeutic parenting. However, the FASD brain needs external support big time, as I'm sure a lot of you'll be aware. It's lifelong and it's continuous, and it can be extreme need for that external support from other brains, essentially. And also linked to that rigidity, you've said it in the Q&A as well about how it's just so rigid, and Beck talked about leave the cheese packet in the kitchen. Here, it's like the military. At times we have to be so routinized, and without that, it all goes very dysregulated. So it's so needed. But at the same time, because of that, we need the autonomy for caregivers as much as possible to counter that, because we need to have spontaneity. Like if we're living a very rigid routine, maybe some people are more kind of like that naturally than others, but some people will need to have more autonomy as well outside of the rigid routine. And then regulate.
Yeah, do you want me to go on to regulate, Anna?
Yeah, great.
Yeah, so in terms of I just want to resonate with the comments on the Q&A that aren't questions so much, Andrew, so they don't need to wait till later. But I just want to say hi, Jill, first and foremost. And Jill's saying, I cannot say no. I have to frame everything as a positive or a yes disguised as a no. So yeah, that demand avoidance profile comes in there as well. And we absolutely get that no can be really hard. So when we go on to clear later and explain that at the end of this, it's really, really important to take that into account. And Jill's saying again, the scaffolding is a big challenge for my older teen moving to adulthood. He needs it but can't accept it. We have had, Jill, people on our course with that age of children, and that I obviously don't have that life experience yet, is so challenging, isn't it? And at that kind of age and stage of life. And what we're saying today as well is, as it is for all people at different ages and stages, applied in different ways. So it's never one size fits all. We know everyone's an individual as well. So just going back to regulate, we need to support yourselves. We talked a bit about that already today, so I'm not going to go too much into it. But if there's one message you take away from this, is that you're not superhuman, and you need to be able to have time to self-regulate. And it's not a given that you'll be able to co-regulate with anybody else if you're completely stressed out, exhausted, and haven't had a break in years. That's just not a reasonable ask. So we're talking about coaching and skills for physical, for co-integration as well. We talked about co-regulation, but not many people talk about co-integration. And if we're talking about our kids' brains being disintegrated, then they need help to integrate them best they can. So we offer insights into nurture for dysmaturity. We've got skills around regulation and integration, resting, and obviously a lot of us know that sensory stuff is so important for our kids. And what are the ways they can regulate? There's not enough discussion or research yet around medication, but we've heard from caregivers that can have good impacts. Again, not for everyone, but from the people that we have heard that from. And like Jill, you were just saying, adaptive demands. So just trying to adapt our language to help that regulation and not bring about more difficulty and challenge than what we're already dealing with. Over to you, Anna, for clear.
So clear, what a lot of people have fed back to us is that the curious wondering within PACE, obviously amazing. It's a therapeutic skill in general to kind of wonder about what people might be feeling. When it's used with children with FASD, certainly in my experience as well, it doesn't really go very well. Oh, I wonder if you're feeling a bit angry. It doesn't always go well. It doesn't go well at all. So what we're saying is there's a need to be much clearer and certain, because the FASD brain, a big part of it is that it can't predict. The prediction function is really affected, along with that rigidity that we talked about that's more familiar with autism, of just not being able to cope with any change and uncertainty. So yeah, unpredictability, uncertainty, ambiguity, change, all really, really hard for the FASD brain to cope with. So you don't want to be, and then when you're bringing in feelings, that's another threat, because it's a very threat sensitive brain as well, FASD brain. So the threat of talking about feelings and questioning them can be really difficult. So it's not that we don't talk about feelings at all, but we could be much more sort of declarative about it and go, oh, panic feeling, or whatever might feel, oh, angry, or more of that sort of stuff for dysmaturity as well. That's another thing. So, dinosaur feelings, or, just making it a lot clearer and a lot simpler. And linked to that is one-step instructions, giving time to process, being really concrete and using a lot fewer words, which, believe you me, is a challenge for me. I just can't. It's so difficult if you're somebody that likes to talk a lot. But it's huge that the FASD brain can't process all that information, and too many questions is also a big demand. So just really dialing it down, much clearer, much simpler, fewer words. Expressive, you may well know already that expressive language is often really ahead of receptive language. So that ability to receive and understand can just take a lot longer and just need a lot less input, basically. And then finally, we've got steer.
Yeah, so last but not least, steer. Yeah. So we know that redirection is something in therapeutic parenting, and what we've done here is adapt that skill, that concept. So it's really about caregivers again, as well as children. So we want to make sure that we are steering in terms of our own needs. And giving firm direction as well as redirection. So it does link with clear in lots of ways, in that we are looking to give our children that reliable, clear, we're in the driving seat, we've got this, it's okay, reassurance. Because ambivalence and the wondering that we've maybe done more verbally with therapeutic parenting and curiously is, like Anna said already, quite scary for them, really, to even have that tone of voice. So we've learned to really steer conversations with, like Anna was saying, very declarative language, very clear instructions, and redirection sometimes is seen as not acknowledging the child's needs and feelings in that moment, especially when it's done as distraction. However, what we hear and what we see is that often people are stuck in a bit of a loop. It's a bit of a brain glitch, whatever metaphor you want to use that's useful to you and your family. And having that maybe space, linking to that concept, maybe having doing something else for a little bit, gets them out of the loop and it gets them out of the glitch without having to use lots of words and talk about it. Okay, so it is quite different to what we might be used to. Rehearsing things can be really helpful. A lot of our kids are really good, you might want to call mimicking, echolalia. You might want to call it, very visual. They can see something and then they can repeat it again and mirror it. Let's use that skill. Let's rehearse positive role playing in terms of maybe friendships, interactions, social scenarios, repeating and reminding and retrying, and repairing, in terms of when it's safe to do so, maybe when we've had some space, and turning it round in whatever way your family finds that works for you. So again, here we use Makaton when we need to. We'll also use more kind of, we're looking at more somatic things. So if maybe I have been not the greatest in terms of I got lost my temper or I wasn't very helpful in my daughter, when she needed me, I'll give her a cuddle and we'll do a kind of a little song and a sway, and I'll gently kind of rub her back or just pat her back, and then we reconnect in that regard. So lots of options there for different families in different ways.
Thanks, Beck. And I just wanted to say as well on that, the steer is also catering to the fact that a lot of the time in FASD, there's not that learning from consequences, and there's not that ability to learn from error and mistakes. So that's why you get, and on a brain level, you get that constant doing the same mistake over and over again. So it's catering to that as well, that the patience that's needed to keep repeating, keep role play, keep trying and trying to turn it around, give them the opportunity to turn it around when they do make the mistake or the error again and again. Okay, I want to leave enough time for the questions because I know people had their hands up before as well. So just finally on this, the caregiver program that we run, in addition to the training that we do, is 6 weeks of 2.5-hour workshops covering the main elements of the FASD brain. And there's also 3 one-to-one coaching sessions using that acceptance and commitment therapy approach that we talked about. We're currently delivering it through Adoption East Midlands, but we're also considering running a program that people can book on in September. So at the end, I'll put a link into the Q&A if I can, to a web page where you can register your interest. So you don't have to do anything or like sign up or anything. It's just to register interest, so that we can know if there's enough interest to run that in September. Okay, so I'm going to stop the share now so that we can have a bit of a chat.
Can I just jump in with a question first of all? A lot of the families that we support at FASD Awareness come from a real mix of family units, from birth families, foster care, adoption, and SGO as well, special guardianship order. Now, one of the things most of our families really struggle with when they come to us at that real final, they're desperate. They're desperate when they come to us and they need support, they need guidance, they need signposting. and they need the reassurances. And one of the things that we find fascinating in our family, parent, carer support groups are when families learn to have to change the way that they parent. It's one of the biggest challenges that they have, first of all, because we're all brought up learning from our own parenting as well. And so to adapt and have to change and put the FASD individual at the center of the new parenting plan, it becomes a real challenge, doesn't it? Have you found this in your experience?
The challenge of changing the way you parent instead of the traditional parenting that you might have been brought up with. Yeah, I think that really connects with the acceptance element of the approach that we use in the acceptance and commitment therapy, because it's a journey really of accepting that this is a brain-based condition. It's not your average experience. This is a brain-based difference, and therefore things need to be adapted. It might look different than you expected, and there's also a loss around that we work on because it's not what people expected necessarily, but through acceptance comes change.
And I think one of the core things that we really want to get across today, and I know you put it as the title of the webinar really usefully, thank you, Andrew, was about the sense of failure around the way I'm parenting currently isn't working. But people in power and authority have told me that this way of parenting has to work. So I'll just carry on doing it. I know Anna had an example of coaching clients who'd been using therapeutic parenting unadapted for primarily trauma and attachment for 10 years and went to see a professional about ongoing issues. Like you're saying, Andrew, people really at the end of their tether, they're exhausted, they're burnt out, they're done in, they just want to do the best for their child, but they're finding it increasingly difficult to cope as a family. And what they're finding is that they're getting that response from the professional who just says, do more of it. Do more of it. And, it's like the emperor's new clothes. It's not working, but I'm going to feel like a failure because somebody professional is telling me it should be working. But in my home, I know it's not. So then when we're coming, or FASD Awareness is coming into people's lives and saying, hey, look, here's some tools. Try them out. And again, what we don't want to be is prescriptive, because we don't want to be the people coming along and telling you, I've got the intervention that's going to support your family, because every family is different and needs it adapted and flexible to their family. So what we really want to build is that parental self-efficacy and confidence that has been really detrimentally affected by these approaches being prescribed to people as if they're going to work for everyone. That's just impossible. It could never be the case. So I think when we lift that weight off people, they feel less blame and shame. They get a bit of their parenting mojo, confidence back, and they really start to think, okay, I'm going to try this, that, or the other. Because the bottom line is, no matter what your child's needs, nobody gave us a manual, did they, when we got them? So we're just working it out as we go along best we can and trying to be a bit more compassionate to ourselves in the process.
I'm also very conscious that many of our families already have siblings as well. For example, if it's a foster placement, let's say, and you've got birth children within the foster placement, having to adapt. And we've always found, and I'm sure you've used it with your therapeutic parenting as well, is everybody has to be on board with this, don't they? And that means that including the siblings in the approach, making sure that everybody's on board with that same approach. Would you agree with that?
Yeah, so shall I speak to this, Anna, because of siblings being in my family?
I only have one child, so it's probably easy for you.
No, it's I mean, in terms of everyone being on board, I can't say that my daughter's siblings are on board with any parenting approach, really, other than they need their own space and we respect that, and we also speak about her needs in ways that help them grow in understanding and compassion. So I think that's been really important for them, because we want to lift the blame and shame off her as well. We want them to understand that she is not being naughty. She didn't mean to do that thing. She didn't understand what you wanted, or that was your special toy that she just destroyed again, or any of these things that come apart. So I guess more than an approach, what we're trying to create within families is an ethos of understanding, acceptance and compassion and kindness best we can, and also giving siblings a place and a space to go that they feel safe outside of the home. Because what we need to recognize is that very often our homes aren't that all of the time.
Yeah.
They can be a bit chaotic, they can be really noisy, they can be overwhelming, there can be high levels of conflict, maybe that aggression that happens because of our kids' needs. So we really need to think, have the siblings got somewhere safe that they can go to talk about this? And I don't think that's taken into account enough in the system, and in post-adoption support or fostering support or SGO support at the moment, that there are kids in that family as well as the child with FASD, that holistic assessment and support needs to be provided. So if that's answered your question, I'm not sure if it has.
No, it has. And I totally agree. We've often, as you are, I'm reiterating what you're talking about today, and that is that when you understand the behaviors, you develop an empathy. Once you've developed an empathy, you're able to communicate more effectively with those individuals. But that includes the siblings as well, and all the professionals that come into your network of support, let's say. So it's really understanding where the behaviors come from, and that develops that therapeutic parenting, doesn't it?
Yes, absolutely. Understanding the brain basis of the symptoms, as many people call them, or neurobehaviors, the behaviors as symptoms of the brain-based condition, then you can think brain, and you can, when it's really horrendous, as it, it doesn't always work to think like that. And, as we've said, when doing the model, it's a spiky profile. Things work sometimes, not all the time. And for us too, sometimes it's just too much. But the basic thing of thinking much younger as well can really help. The dysmaturity, the half age principle, emotionally and socially. So you go, they're really dysmature and their brain injured. I mean, people like different phrases for that: brain differented, brain, but essentially it is a brain injury caused before birth. And so seeing it through that lens means that you can have more empathy. Exactly, Andrew. More compassion and empathy.
Absolutely.
Yeah.
We've got a question here from Michelle. Prior to a neurodevelopmental paediatrician flagging a concern re FASD for my 12-year-old adopted daughter, during an assessment for autism, our post-adoption social worker suggested a sensory and therapeutic parenting training course. We've implemented PACE with limited success. Now we believe our daughter has FASD due to 3 sentinel facial features and a small head circumference. Our post-adoption social worker has questioned why I'm pushing for a diagnosis. Any tips on dealing with professionals who make me feel like I'm doing something wrong in seeking and confirming diagnosis? We hear this time and time again.
We hear
Over
it time
to
and
you,
again.
please do.
Crazy,
it's so frustrating. Go on, Anna. You say your bit.
Well, I'll say my bit, then you can say yours. Yeah, one of the things that we're one of the goals of the work that we're doing is to build confidence and conviction for people, so that we can go, no, this is what it is. Because so many people feel cautious, I think, about naming it as FASD until a diagnosis, or until, even then it can be, so what we're trying to encourage is seeing through that lens, even without a diagnosis, and then having the conviction and the belief to basically say to professionals, no, I know what it is, and this is what it is. And in the face of that denial and that dismissal And that ridiculous thing about why would you want a diagnosis? And bet you probably say this, but you know, it's often, you often say, don't you, like if you had cancer or Down syndrome, would you say, oh no, you don't want a diagnosis? It's just crazy, isn't it? But yeah, it happens time and time again, and we work on with caregivers building that conviction and that belief and that confidence to be able to assert this is it. And it's the professionals that don't know.
Yeah, I think I've kind of got two heads on here. One is I am a social worker and I am a proud social worker for 20 years. And yet we have experienced very poor social work in this family and been let down, as many of our families have. And in my parent carer focus groups and interviews, I was very often significantly impacted emotionally by what people were saying, what they've been put through. And all I can say is, what's really helped me, Michelle, with that, and first of all, I can't get into your particular situation with your child, Michelle, but I did want to just quickly say is, you know, you don't need sentinel facial features and you don't need a small head circumference to get a diagnosis under the NICE guidelines. Yeah, so the diagnosis is either FASD with sentinel facial features or FASD without, and the great proportion of people will be diagnosed as FASD without. But as Anna said, the even greater proportion of people in the world will never have their FASD diagnosis. And that, again, is part of our realism and our acceptance about what can we do. And what we can do is bring to light that brain-based lens, look towards thinking of it as FASD and looking towards those adaptive functioning deficits that we've all kind of explored today in terms of regulation, sensory needs, memory, processing, language, communication, social difficulties. Those deficits will show up without a diagnosis. So if we have proof of alcohol use in pregnancy, that's the fundamental thing, and that's very difficult too. So this whole area is laden with stigma, and for me as a professional and as a mum, it's really helped me to understand that, because we are all living under the shadow of that in this area, professionals and parents, foster carers, caregivers. Yeah, so when we're living with stigma, what is the most comfortable position is to push it away. Push that thing away. I don't want to have to deal with it. I don't want to accept it. And I don't want to confront it. It's too hard. FASD is one of society's most uncomfortable truths. So I really think that that's helped me have a bit more understanding of where professionals are coming from. We have to live with this truth, because I'm confronted with it every morning when I go and wake up my beautiful daughter. The reality of her life is not something I have the privilege of escaping from, even though some days I wish I could, to be honest, you know, just the experiences she's been through and the heartache and pain. But professionals do get that choice. And of course they're going to move towards that. And I think social work in particular comes from an ethos of, we don't want to pathologize, we don't want to label children particularly. And unfortunately, that's caused an inverse oppression to occur in this area, and an inverse discrimination is what my kind of research is about, in that by not declaring the truth and by not living with this brain-based reality that we're all living with, we're actually making people's lives harder, you know.
Thank you for that. And I totally agree. And I think having that lived experience that you both have, it really sort of enforces that through your teaching and your course. We often say to our families that there is such a lack of knowledge of FASD, even now in all sectors. And yet it is one of the most prominent cases that we're going to be finding in years to come. And yet one of the points we really stress to our families is embolden yourself with information. Use the language, use the knowledge that you're getting as you are today by coming on this webinar as well. It forces you to find the language and the confidence to go, do you know what, as we recommend to many of our families, is you are the FASD specialists. You are the FASD specialists. You are the FASD advocates. And so therefore, if these people that you're having to manage and deal with don't understand FASD, there is a very subtle and very delicate way of managing it, because you don't want to insult them, because you'll get nothing back. What you need to be is diplomatic in your approach, and that is ask how much information they know about FASD, and leave it at that, because they will go away, and if they're professional, they will want to understand a little bit more about it, so that they don't feel embarrassed in that situation. And we've had many pediatricians, we've had many doctors, GPs come back to us and actually say, we needed to be informed, we needed to know more. We're not being encouraged to understand these areas. We have to learn so many things, but FASD is not in the public domain like you would expect it to be at this stage in one's life. Over to you, Anna. You've been looking at some of the questions coming in as well, I notice.
Yes, I just want to make sure that we speak to some of these questions. So anonymous person has got a question about confabulation with a young adult, a 19-year-old. How do you react to that without invoking shame? Yeah, it's tricky for the young person wanting to make and keep friends. Yeah, it's really tricky. And that's something that we'd have to kind of look into more detail than we can do today. But the main thing about confabulation is that obviously it's a brain-based issue of filling in the blanks. So yeah, basically the thing that can work is to not kind of counter it, a bit like in dementia, you know, when people confabulate, you can, unless it's really unsafe or really causing harm, then it can work to be like, oh, okay, you know, go along with it as much as possible. But you're potentially saying that it's interfering with friendship, so that gets tricky. I can see that.
Yeah.
Can I come in on that one as well? Sorry,
go on,
Becky, you come in immediately after me, if you will. But I just wanted to suggest that Maggie May, phenomenal advocate of FASD and young lady with FASD diagnosis, frequently says in our training and our presentations that if you know it's not harming anybody, if you know it's not impacting on anybody else or becoming a safeguarding issue, just let it go. Because in their mind, it's true. It's like having two jigsaw puzzles and you've got two pieces that fit perfectly well, but in the wrong jigsaw. It doesn't make that picture complete, but that's their complete picture. Obviously, if it's a safeguarding issue, you need to manage that, and you need to understand how to have that conversation with them. Becky, over to you. Sorry.
Yeah, no, I think I was going to say something similar, Andrew, just along the lines of it again. It might sound like a broken record. This is part of your disability. We are trying to teach people self-advocacy skills. We are also trying to teach parents and caregivers advocacy skills. Let's name that. You know, when we're talking therapeutic parenting, let's name it to tame it. Let's name the truth of the fact that you have a disability where sometimes your brain wants to fill in these gaps, and that's okay most of the time. But right now, in terms of your relationships and friendships, which I know mean so much to you, this is causing a problem. So let's have a look at what we can do around that. Sometimes we can't do anything about it, but at least we're being honest that this is an issue, and we totally get that you're not making up lies and you're not trying to cause a problem here. You know, I think that lifts the blame and shame to just name what's going on as part of this person's disability related needs, as you would with any other disability. You would talk about it very openly. I know that might not have happened for a lot of our kids because that hasn't been the skill we've been taught. But that's something that can be, I think, really helpful.
On the other hand, somebody else also put into the chat, could be the same person, about false allegations against them and social worker police involvement. That's quite a common thing that we hear about as well, isn't it?
Yeah.
And again, then it can help to be really confident in FASD and the fact that it is confabulation and it's a brain-based disability and it's coming from that, so that then it's very clear that the allegation against you is coming from that and isn't isn't true. So, if you have the conviction, again, like we've said before, to be able to say, no, this is why it's happening.
And
And this
another
is,
point, sorry, just
yeah,
jump in on that as well, because it's really important as well, because these are families' lives, and many people that have to deal with allegations, and we've done a webinar on it as well, it can be absolutely damaging to a family environment. And when you've got professionals that don't understand what confabulation even is, or why it is a break, they see it as lying, or they see it as the truth. And this is so frequently the vulnerability of our many of our individuals with FASD. But one of the things that this has come from many of our FASD friendship groups, and these are individuals that have a diagnosis of FASD, and what they say is, if you're questioning confabulation, ask the next question. And Gilbert does this as well up at Salford, doesn't he? In his work, is go and ask the same question again a few minutes later and see if you get the same response. Add something into it and say, and put a suggestion that is completely out of the park, and see if they agree with that, because frequently many of our individuals will actually want to please you. And so therefore that is another way of being able to train the professionals to understand confabulation. Say, well, go and ask them the question again. See if you get
And
the
I
same
think
response.
this is where it's really helpful if our families can have professional reports and clarity around assessment and need that we're not getting, all we're paying privately for if we can afford it. It's really unfair and unjust. But if we do have that backup and we have got that kind of weight behind what we're saying, that can also really help. It also helps to understand what kind of a social worker you've got in front of you who may or may not understand these matters. So one of the kind of things that's coming up in my research is that we're getting so many different kinds of social workers coming in our lives, and maybe they're not explaining their role as clearly as they could, either to us or to our kids or young people. So we might have a child protection social worker, so they are going to be thinking through that lens. We might have trouble getting hold of a post-adoption social worker, but if we can, that's really helpful in these scenarios, because their job is to understand adoption. I know they're not necessarily trained in FASD, but if they're not, please tell them about us. And their job is to advocate and support our family as a whole. So they should see different sides to that, situation as well. The other kind is you could get your disability team social worker, which again, I know we're having trouble getting access to them, but they again should be seeing this through a disability related lens. And last but not least is, as we've got young people coming into adulthood, you might get an adult social worker involved if there's confabulation and allegation going on. And then I would be expecting them actually to have, this is my hypothesis anyway, you can all tell me I'm wrong, it's fine. They've got skills. I've practiced for years now using the Mental Capacity Act. So what Andrew's saying, those skills around asking questions differently, rephrasing, looking at suggestibility, those are all about, can this person clearly communicate a decision? Do they understand the information that they're using? Can they really apply it in this context? Those are all Mental Capacity Act skills and assessment skills. So you might actually find that language helpful, in those kind of scenarios. It's not a mental capacity assessment, but I'm just saying these are transferable skills. So yeah, it depends what social work you've got in front of you as to what capacity they've got to really understand those nuances, I think.
Ladies, I thank you so much. I mean, we could keep going, and I'm really happy to keep going, because I think a lot of the conversation that we're having here, and one of the creations of Neurowise was because from your own lived experience, you understand the need of families, and you understand that we've seen it with our charity, and the reason the charity was set up in the first place was because we are all so isolated in many ways. And that's why the FASD community is such a strong community, because we get each other. We understand the challenges because they are so different to most others with a brain-based injury in the case that it is. And I thank you for the work that you're doing in supporting families and helping with a more therapeutic parenting style based on understanding and knowledge and that empathy that we speak about, which is so important. But it's also about actually saying to yourselves as well, do you know what? Give yourself a tap on the back.
Yeah.
You're amazing. You're all amazing.
I
But
always
what
say
you
that,
do,
Andrew. You know, people are attending this webinar tonight when they're exhausted. They've had a
yeah,
hard day. They're all here. We're trying. We're turning up for our kids and young people. And I just want to, lastly, Andrew, I will stop talking, but just address Annie was saying she's frightened for the future. And the last thing we want to do is exacerbate those fears. We genuinely believe and we see there is hope. And we know that when FASD is supported, people can have great outcomes. And what you're doing here tonight is supporting the person you love with their FASD and their disability related needs to kind of really start moving towards that hopeful future. So I really hope that that's, you know, a message you can take away as well.
I totally agree. I mean, we always like to finish on a positive because there are too many negatives around the work
Yeah.
that we do and our families and our FASD individuals. But we always stress the importance that with the right level of scaffolding and understanding early on and the right level of care and support, it can lead to positive outcomes. We've seen it happen. And there are so many advocates, FASD advocates out there, and more coming out each year, singing the praises of individuals and a successful life with the right scaffolding and support and understanding. You can lead a very positive life as an FASD individual and an FASD family. So thank you all so much for joining us tonight. Anna and Becky, really
Thanks,
appreciate you.
Andrew.
You know we're going to have you back on again at another time
That'd be
as well.
lovely.
So it's been a real pleasure. Thank you so much for joining us. And we wish all of you the very best of luck in your journey, and come and find your support in our FASD community. Best of luck. Thank you all so much indeed.
Everyone. Bye now. Bye.